And this is even more so the case with COVID-19 because there's actually a risk that even though the person is no longer alive, they can still spread the virus to the medical examiner. So these autopsies are pretty rare, and when there is an opportunity to do them, we really have to cherish the medical information that we can glean from them. So now there's another study that came out where there's 18 cases of people who died of COVID-19 where they did the autopsies. So if you've seen my previous videos on autopsies that were done on COVID-19 patients, it's pretty clear by now that when patients do die of this virus, it's because of the lungs, either because of all the inflammation in the lungs with pneumonia and cytokine storm and ARDS, and sometimes with multi-organ failure, or they die because of a major blood clot that develops in the lungs. Sometimes, though, blood clots show up in other parts of the body as well. For example, in some cases, clots can travel to the brain and lodge in the blood vessels there, causing decreased blood flow to certain regions of the brain. This is known as a stroke. But this virus, in a different manner, can cause neurologic symptoms in some people, such as headache, confusion, and anosmia, meaning loss of sense of smell. But we don't know why this virus is causing these symptoms. Is it because the virus travels in the bloodstream to the brain? Maybe. After all, there are ACE2 receptors that are located within the brain. Is it because the virus gets in our nose and uses the olfactory nerves that are there to gain entry into our brain? Maybe. Or are these symptoms more related to effects of the cytokine storm, which is actually pretty common with infections in general, whether that be from pneumonia or something else? Now, in this recent study in the New England Journal of Medicine, they looked at brain findings from autopsies done on 18 patients who died of COVID in a single teaching hospital. All 18 of these patients had nasopharyngeal swab samples that were positive for SARS coronavirus 2 on PCR. So 14 out of the 18 were men. The median age was 62 years old. 12 out of the 18 had diabetes, 11 had high blood pressure, and 5 had other cardiovascular disease. 4 of them had chronic kidney disease, and another 4 had a history of a stroke, and another 4 had dementia. When they went to the hospital, 3 of the patients presented with myalgias, meaning muscle aches or body aches. 2 patients presented with headache, and 1 patient had a decreased sense of taste and smell. So the patients had presented a median of 2 days after the onset of the first symptoms of SARS-CoV-2 infection and were hospitalized for a median of 6 days before they ended up dying. 11 patients ended up requiring mechanical ventilation, meaning a breathing tube. So interestingly, it was noted that all of the ventilated patients had a confusional state or a decreased arousal from sedation for the ventilation. So whenever we have patients on the ventilator, we have them sedated so that they're comfortable with that breathing tube that's going down their throat. The way that I interpret this is that when they pause the sedation, meaning they temporarily stop the sedation to assess their mental status, the patient was not able to follow commands during that time, which in general is not uncommon, but this does seem to occur more often with COVID patients, and this is something that I've been finding in my COVID patients in the ICU. So on these 11 mechanically ventilated patients, they didn't do a brain MRI or any EEG testing or any lumbar puncture to look at the cerebrospinal fluid, the CSF, aka a spinal tap.
Don't touch it. Don't touch it.
I wasn't going to touch it.
No, don't touch it.
This is likely because doing these tests is more challenging in someone who's intubated and sedated, who has this extremely contagious virus. So there's always the concern of potentially exposing more medical staff to the virus and spreading that virus throughout the hospital. However, they did do a CT scan of the head on 3 of the patients, and for all 3 of these patients, they didn't find any acute structural abnormalities. On average, these patients died about 10 days after being admitted to the hospital. So when they did these autopsies, they looked at the brain as a whole, and also they sampled 10 different areas of the brain and then looked at those samples underneath the microscope. So there was atherosclerosis in 14 out of the 18 cases, and there weren't any that had any stroke or abnormalities to the olfactory bulb. The olfactory bulb is the part of the brain that is responsible for sense of smell. So microscopic examinations showed that there was acute hypoxic injury in some regions of the brain. So acute hypoxic injury means tissue was damaged as a result of not getting enough oxygen. So there was acute hypoxic injury in the cerebrum, which is the part of the brain that allows us to think and be conscious. There's also acute hypoxic injury in the cerebellum in all of the patients. And there were no blood clots in the brain, and there wasn't any vasculitis, meaning there was no inflammation of the blood vessels. And it's significant that there was an absence of vasculitis. We know that in kids, there's this Kawasaki-like disease and multi-system inflammatory syndrome that occurs with COVID, which is essentially a vasculitis. So at least in these 18 adult cases, we can say there was no vasculitis in the brain. In one case, there was focal leptomeningeal inflammation, which means there was inflammation of the meninges, meaning the lining of the brain. So essentially, it's sort of like a meningitis. So another thing that we want to know is the virus actually invading the cells of the brain? So in this study, they actually tested the brain tissue for the virus with RT-PCR. In 2 patients, they sampled 10 different sections of the brain. For the other 16 patients, they sampled 2 different sections, one from the frontal lobe and the olfactory nerve, which kind of is lumped as one, and then the other part was the medulla.
The medulla oblongata.
Mama
The medulla oblongata.
So for all the 18 patients, they only found the virus in 3 of them. And when they found it, it was located in the section where there's the frontal lobe next to the olfactory nerves. It's actually in the olfactory nerves and the frontal lobe. And then the other part of the brain they found it was in the medulla oblongata. So in conclusion, for all 18 of the patients, really the only brain damage or brain injury was a result of not getting enough oxygen to the brain. The reason why these patients had hypoxic brain injury is because their heart could not pump enough blood to the brain, which happens when the body is in severe shock, and also what happens when people go into cardiac arrest. So when there's not enough oxygen getting to the brain, it could be due to one or a combination of these reasons. It could be either due to the heart not pumping enough blood there, or it could be because the lungs aren't getting enough oxygen into the blood, or it could be both reasons. So also what's been demonstrated in other studies, which I made a video on this called 12 Autopsy Cases, we know that when people die as a result of COVID, it's either because of the massive inflammation in their lungs, which means ARDS and multi-organ failure, but also the other reason why they die is because they have big-time blood clots in their lungs. So either one of these can lead to the heart not being able to pump enough blood to the brain. So this is a state of shock. And also, eventually, this leads to the heart stopping or cardiac arrest. So when someone's in severe enough shock and or cardiac arrest, that heart can't pump that blood to the brain. And that's why you start seeing the brain cells having hypoxic brain injury there. So it's still not clear why some people have neurologic symptoms with respect to COVID. It's possible that the olfactory nerve, which has nerve endings in the nose, it's possible that the virus invades this area, and that could be a possible explanation for anosmia. After all, we know that there are ACE2 receptors in the nose. As for the other symptoms like confusion and headache, that could be due to the cytokine storm that takes place, which is initially triggered in the lungs with the massive inflammation there. We know that certain participants in the cytokine storm, like IL-1 and IL-6 and interferon gamma, they can cause body aches and headache, which is the same reason why people often have these symptoms with the flu. And confusion and or delirium is actually a very common phenomenon in the ICU way before COVID came along. So just being sick enough to actually require a stay in the ICU is enough to cause delirium. So it's hard to know if COVID itself is making people more prone to delirium or not. And there are more and more studies that are coming out every day, and we keep learning new things all the time. Before I say anything, I just want to say that if you are squeamish, you might not want to watch this video, because there will be some pictures of lungs that have a blood clot in them and other organs of the body. In my opinion, it's nothing that bad, but I wanted to give you a warning regardless. This video is a follow-up to my last video, which was called What Doctors Are Learning from Autopsy Findings of COVID Patients. Just after I published that video, not even a day later, this study came out, published in the Annals of Internal Medicine, which I'll put a link in the description below. And what makes this study such a big deal is that it's the first study that looked at this many autopsies of patients who died of COVID. Not only did they do complete autopsies, but they used CT scans to scan the entire body for blood clots. All 12 of the deceased had tested positive for SARS coronavirus 2 by means of RT-PCR. Now I want to say something. Not everyone on this planet is going to get COVID. For those who do get the virus, 80% of them will have either mild or no symptoms. Roughly 15 to 20% of them will have pneumonia. Roughly 4% will develop ARDS, or acute respiratory distress syndrome, and or shock with multi-organ failure. And about 1% will die of the infection. When I'm in the ICU and someone dies, it's obviously horrible. Sometimes autopsies have to be done irrespective of family consent when it's a legal matter. Rarely, depending on the circumstances, we ask families permission to do an autopsy. Most families decline the option for autopsy. But during this pandemic, it's especially important for autopsies to be done because they often provide incredibly valuable information, especially when we still know so little about COVID, especially when it can present in so many different ways. So in this study that was done in Germany, autopsies were mandated for patients who died of COVID. And to the families of those victims of COVID, my condolences. And we're still trying to figure out why some people do so poorly when they get the virus, while others do just fine, and then there's everyone in between. So the point of this video is not to scare people. The point is to learn about the disease and to ultimately benefit from that learning with the hope of developing treatment options and ultimately reduce morbidity and mortality. In other words, to save lives. And by making this video, the goal is to educate myself and others about what we're learning and getting the medical truth out there to the public. So in this study, there were 12 patients total, 9 men, 3 women, and the median age was 73. All patients had some type of pre-existing medical condition. Most of them had obesity and or underlying heart disease, such as coronary heart disease. Some had type 2 diabetes, hypertension, peripheral artery disease, asthma, COPD. Initial lab tests revealed elevated levels of D-dimer, lactate dehydrogenase, meaning LDH, and C-reactive protein, or CRP. All of these are non-specific markers of inflammation. There is also mild thrombocytopenia in some patients, meaning low platelet counts. This isn't an unusual finding in patients who are critically ill. They also looked at levels of viral RNA using RT-PCR studies. All 12 patients had the SARS coronavirus 2 RNA in their lungs. 9 out of the 12 had it in their throat, and 6 had it in their bloodstream. In 5 patients, they had viral RNA in other tissues like heart, liver, brain, and kidney. Not only did they have the virus there, but the levels were higher in those tissues compared to the blood. Here's a picture from a different autopsy that was not part of this study, where the virus was actually visualized in the kidney using electron microscopy. So what is this telling us? It tells us that the virus is binding to those ACE2 receptors in those organs. So in some people who die of COVID, they had the virus in other organs besides the lungs. But, and this is a big but, they did not die as a result of that virus being in those different organs. They died as a result of lung complications. Also, an important takeaway from this is that all 12 had it in their lungs and 9 out of the 12 had it in their throat. So when you go to do a throat swab of someone who has COVID, the virus might not even be there. And that's just another reason why you can get a false negative test. Okay, so they also did post-mortem CT scans of these patients, which demonstrated mixed patterns of reticular infiltrations and severe, dense consolidations in both lungs. This CT scan is a patient with COVID pneumonia and ARDS, not from this study that we're talking about now, but basically demonstrating the exact same thing. Both lungs have extensive consolidations, ground glass opacities, which represent extensive inflammation. These are also known as pulmonary infiltrates. And you can see the difference compared to a normal CT scan of the chest, which doesn't have any pulmonary infiltrates. In 4 cases out of the 12, massive pulmonary embolism, meaning massive blood clots in the pulmonary arteries, was the cause of death. In another 3 cases out of the 12, they had blood clots in their large veins of their legs, meaning DVT, without having pulmonary embolism. So in 6 of the 9 men, they had clots in the veins that surround the prostate gland. In all 12 cases, the cause of death was found within the lungs or the pulmonary vascular system, meaning within the pulmonary arteries. For the ones who didn't die of having a large pulmonary emboli, they died of the extensive inflammation within the lungs, meaning pneumonia with ARDS. In these cases, the lungs were wet and heavy, much like a sponge that is saturated with water. The surfaces of the lung often had a distinct patchy pattern, with pale areas alternating with slightly protruding and firm, deep reddish blue hypercapillarized areas. This is indicative of areas of intense inflammation with endothelial dysfunction that can be seen at the microscopic level. When they look at slices of the lungs under the microscope, they found diffuse alveolar damage in 8 cases out of 12. Specifically, they saw hyaline membrane formation, tiny clots in the capillaries, and capillaries that were engorged with red blood cells and other inflammatory findings. All these findings represent ARDS. They also found lymphocytes, a type of white blood cell that infiltrated these specific tissues. This fits the picture of a viral pathogenesis. They also looked at the pharynx of these patients, meaning the throat. The lining of the throat, or the mucosa, was hyperemic, meaning very red and irritated, and at the microscopic level, they saw lymphocytes invading there as well, again, which is consistent with viral infection. In one case, a patient had lymphocytes invade his heart muscle, findings that are consistent with what we call viral myocarditis. In other words, the heart muscle had evidence of viral infection. More than half the patients in this study had large blood clots. 1/3 of the patients had pulmonary embolism as the direct cause of death. All the others died of intense inflammation in their lungs related to pneumonia and ARDS. Recently, there's been studies showing that about 1/3 of patients with severe COVID have blood clots. Another study of 191 patients with COVID-19, half of those who died had clots compared with 7% of the survivors. And levels of D-dimer that were greater than 1,000 were associated with a fatal outcome. So it's pretty clear now that SARS-CoV-2 virus is causing a lot of clots to form in moderate to severe COVID disease. But how is this happening? It's likely a combination of reasons that have to do with downregulation of the ACE2 receptor in the lung alveoli, with a subsequent shift towards having more angiotensin II in the lungs and less angiotensin 1.7 and less angiotensin 1.9 in the lungs. And when this happens, this leads to more cytokine storm with more inflammation, more constriction of pulmonary arteries, and more clots that develop. That in turn leads to more endothelial dysfunction in the capillaries that surround the alveoli. Also, there's evidence that the virus attaches to the ACE2 receptors of the endothelial cells that line those capillaries, which further propagates inflammation and clotting. And in the cytokine storm that develops there, RANTES, a chemokine, binds to the CCR5 receptor of CD4 and CD8 lymphocytes, and that causes those lymphocytes to infiltrate those areas of inflammation, and in doing so, further contributes towards the inflammatory reaction. This is why we're seeing low levels of CD4 and CD8 lymphocytes in severe COVID. Endothelial damage can also lead to the development of antiphospholipid antibodies, and these antibodies are bad because they trigger the formation of blood clots. And that's why patients who have clots with the diagnosis of antiphospholipid antibody syndrome, they need to be on blood thinners. Also, 11 out of the 12 patients in the study had underlying heart disease and were obese. These are known risk factors not just for cardiovascular disease, but also known risk factors for endothelial dysfunction and are known risk factors for COVID. The endothelium is more susceptible to damage based on cardiovascular risk factors, such as men age 45 or older, women age 55 or older, smoking, high blood pressure, high cholesterol, diabetes, obesity, and lack of physical activity. So the big takeaways from the findings in this study is that most people who die of COVID, it's primarily a lung problem, either related to inflammation with ARDS and or blood clots. Even though blood thinners are not a cure for COVID per se, they do have the potential to save lives. The hard part is figuring out who is likely to develop clots and who should we give blood thinners to, and which blood thinners should we give, and should we give high doses of blood thinners or just the low dose prophylactic doses. To further complicate matters, it's often hard to diagnose blood clots in hospitalized patients even before COVID came along. Usually it's easy to diagnose large blood clots in the veins of the legs, meaning DVT, by doing an ultrasound of the legs, even though ultrasound isn't 100% accurate. The way we typically diagnose pulmonary emboli is by getting a CT scan of the chest, while at the same time giving IV contrast, and this is called a CT angio or a CTA of the chest. The downside to doing this, well, there's several. One, you have to transport a patient to the CT scanner, and sometimes patients aren't stable enough to do that. 2, you risk spreading the virus to others in the hospital by transporting that patient, and this will also require more PPE use. 3, CT scans require larger doses of radiation. 4, giving someone IV contrast has some risks, such as the risk of serious allergic reaction and the risk of causing some kidney damage. On top of that, the CTA of the chest can only visualize bigger clots, so you might not see the small clots that are there. Right now, more and more hospitals are giving high-dose blood thinners to COVID patients who have severe disease, even if they haven't been diagnosed as having blood clots. But what about patients without moderate or severe COVID? Should they take a blood thinner or maybe a low-dose blood thinner? Or should they take an antiplatelet medication like aspirin, either 81 milligrams of aspirin or 162 milligram dose or 325 milligram dose? Or should the general public take a low-dose aspirin like 81 milligrams in order to help prevent blood clots from forming if they do get COVID? Or should it just be certain people in the population who are at higher risk of getting severe COVID? Should they take aspirin? These are the questions we don't know the answers to at this point. It's going to take a lot of studies to answer these questions, because not only do we need to know that there's a benefit in doing so, we have to know that these benefits will outweigh the risks, such as the risk of bleeding. And then there's all the other drugs that are being looked at right now in randomized controlled trials. We should start seeing some of these results pretty soon. What we do know is that in order to improve the capillary endothelium and also to minimize your chances of having severe disease if you were to get COVID, you want to do several things. This includes exercise, eating healthy, getting good sleep, minimizing stress, not smoking. What about vaping? Generally not good either, but not as bad as smoking. Too much alcohol, not good either. Have your medical conditions under control, whether that's diabetes, high blood pressure, COPD, asthma, allergies, whatever the case may be. Now, what about vitamin D? Probably a good thing, but that's a whole nother topic, which I should make my next video on because there's a lot to say about that, and possibly other vitamins too, if you're deficient in certain vitamins.